So I'm going to share, going into basic science, a very much needed innovation to grasp real visual field loss. So animative perimetry is something, as you can see this two-dimensional cone here, and when you see it on top, this is how it looks, right, in our 2D printed. But visual fields is actually a three-dimensional graphic representation, and how does it really look? So this is my animation grid module that I made to show the points of all the points that we are going to test. And then does it really look like this, real differential light sensitivity? In the macula, if you see, you'll be able to see the dim light that the macula is sensing. Slightly away from the macula, you'll be able to see a much brighter light. That is why the values are, lesser when you move away from the macula. And when you move more to the periphery, it will look even more brighter. So this is where the numerical grid that you can see the numbers, right? 30, 31, and in the periphery it's 22, 27. So this is an animation module that I made where, for example, to evaluate a scotoma, what is a relative scotoma? You can see the weaker stimulus is seen, but it's not seen, but a brighter stimulus is seen. Absolute scotoma, localized defects, and this is a differential light sensitivity. And I'm also going to show you some 3D printed modules of these innovations that has been made. Isopter contraction. So in normal, if you see, the macula is not able to see the dim light which was perceiving once, but now it is only able to see a much brighter light. Similarly, on the paramacular regions also, if you see, the dimmer light which was perceived once is not able to be perceived. So it's a teaching module which helps you in understanding the cognition of an isopter contraction, and even for kinetic perimetries, like how the isopters really contract. You can see the stimulus 1E, 2E, which is now not there in the isopter contraction because it gets shrunken, right? The small stimulus are now not being able to see. And then the real-time grayscale pictures that you see, this is the animation showing the 30-2, how 6 degrees apart they are, and how 3 degrees apart they are from the horizontal, and the -2 meaning that they are just 6 degrees apart. And 24-2, all the peripheral points are removed. And then in the 10-2, in 24-2 strategy, you are able to see 12 points, whereas in 10-2, you are able to see 68 points. So this is a teaching animative module that has been made along with testing strategies, the CETA that we see, the staircase algorithm. So in the staircase algorithm, what happens, my dear friends, you see the black arrow, 4 decibel gets incremented, and then you come back 2 decibels. So for example, if this is the seeing area of the patient, the yellow arrow that I am showing, see how the machine operates. First, it shows you this point, that is the brightest stimulus. It reduces 4 decibels, it reduces another 4 decibels. Now it reduces 4 decibels, the patient is not able to see because his foveal threshold is now altered. Now it goes back another 2 decibels, and there the patient is able to click and is able to understand. This is the fine tuning of the staircase algorithm. Let us see how it happens in a real time. Only one point is taken, decibels are reducing, reducing, not able to see. A 2 decibel is increased and he is able to see. So this is an animative grid where all the strategies are made. Along with the animations, I have also made a 3D printing module which I am going to show demonstration, where this is the last part of it, where I have 3D printed the visual fields, because you get to understand the scotomas much better. What is an isopter contraction? What is a real 3D visual fields? And last but not least, for the patient, what is actually expected from the patient? From a student's point of view to a patient, how does he see the points? His eyes are occluded. So what is the fixation target videos that he see? And finally, if you see this video here, so this is a video showing how the patient actually perceives the point. So once he takes this video, he'll be in a real world for better demonstration of the visual field. Thank you once again for this opportunity.
Thank you. Thanks for sticking so much into.
This is the models that I want to show.
Yeah.
So 3D functional analysis is something that we are thinking in a 2-dimensional plane, because we see this from a top angle. So basically, can we island of vision in a hill of darkness, if we are able to print it, and this is an arcuate scotoma that you can see. The idea is, if the scotoma is steeping very acutely, or is it steeping very slowly? So 33, 27, 25, or is it from 33, it is immediately dropping to 0. Like an NTG where the fixation is steeper, deeper and more closer. This scotoma is more of a sloping scotoma, whereas in NTG you will immediately drop down. So this gives us an idea of how the 3-dimensional functional visual field is remaining. And we are all used to see this isopter contraction in the book where you get the one hill and another hill is shallow. But what it really signifies is if 33 is moving to 22 at periphery, it starts with 27 and slowly decreases. The whole points are coming down. So this three-dimensional representation will give us pedagogically a better view on how to interpret the visual fields, and also to the patient who's going to take it, if we are able to show a video of how the points are, how the cross-section target, because in literature there was no animative teaching module or videos for the patient. So that's why we made this, and thank you, ma'am.
Santosh.
Nice innovation. How we can use it in our daily practice?
So one is two components, sir. For the students or for teaching, that is a one component where you can actually show them each points, because each grid has been now animated, and the staircase algorithm, or you know how the visual field points happens in a clover leaf, and then it slowly demonstrates. So basically we don't get to do, either we do the visual field and then we know how the machine operates, or we need to make pedagogical teaching videos like this, which will accelerate learning for the fellows or the students, because they should know what to expect from the machine. And second thing is the patient, sir. If the patient learning curve is a very, very big hindrance, if we make an animative video of once he sits, what is the target he is going to see, where and all the points will come, what will be the stimuli sizes or the intensity. So once he sees those videos, he is now understanding how to go about it, because now when he places his chin, he'll be able to know how he should go, and the learning curve is able to accelerate. And this teaching will help us accelerate the patient's output also, because visual field is somewhat a demanding task as of today. So that is where I see this video based teaching module will help the students and the patients as well, because they know what to expect from the machine when they are put on to the machine. Yes, sir.
Thank you.
According to an illiterate patient will be more comfortable with automated perimetry after going through these classes.
Yes, sir. This is more like a pre-counseling of the visual fields rather than putting him into the machine and he is completely unaware, and then we depend on the funders or OCT. We have this module and put him into the machine, sir. Yeah, him or her.
Yeah.
In different languages?
Sir, as of now, it is a visual language that we have created, but it is definitely capable of putting it in under any regional language, because the video-based
Anahita?
animations are all visually depictive rather than languages, sir. It's like they go in, keep their chin, then the points start appearing. So it's as if an immersive experience of what he can actually expect. Language should not be a barrier, sir. Yeah.
Thanks, Prasanna.
Thank you, ma'am.
Thank you
And the
very
videos
much.
are all open access, which are available on YouTube as well as other platforms. Yeah.